I've been invited to talk a little bit about our involvement with COPD. I go a long way back to COPD and have been involved in some of the initiatives that got everybody's interest stoked in COPD. For most of my career, I've been saying we don't pay enough attention to COPD and the patients who suffer from it. And now there's no shortage of attention to COPD. And in fact, we're almost in competition for various projects we're participating in, and I'll try and show you some of those. Always start with a disclosure slide. I have done some speaking and consultation work for basically companies that make puffers for people with asthma and COPD. My objectives are as follows. I was asked, actually, we had a conference call about what they wanted me to talk about, and they listed topics that would be about 4.5 hours to cover in completion. So I'm going to do them all and just talk really fast. I decided to pick just a few, and I was asked to look about implementing best practices, and I'm going to show you how we've done that. I was asked to look at measurements and what success looks like, and that's actually a really complicated question, because although there's lots of measures discussed, none of them are really validated to show the benefit of some of the interventions we do. I'm going to talk a little bit about anything new about acute exacerbations. We provided some slides from the 2008 Cts Guidelines of how to manage exacerbations in medical practice, and the recommendations have not changed a lot, although there is a couple updates I'll share with you. And finally, not to rain on anybody's parade, but just look at some of the limitations of some of this work and the fact that out there in the real world, our good intentions don't always work as we anticipate. But first, I'm going to start with a little bit about quality-based procedures, which was actually the impetus for a lot of interest around COPD, because the ministry threatened to fund hospitals based on their quality of care of patients with CHF, COPD, and other frequent conditions. And I was invited to be on what was called the expert panel for COPD back in 2011 and 12 when this first started. And how do you become a quality-based procedure? Actually, I just have to keep track here so I can use the pointer if I need to. The ministry can watch these things, obviously, from Queen's Park and determine that there is a lot of practice variation in looking after patients whose charts are coded as COPD who are admitted to the hospitals. And I'm going to share a couple of those variations with you. Across regions, across providers, across different populations. We have pretty good evidence for how to care for exacerbations of COPD. We wish we had more. That's one of the limitations, but at least the evidence exists. And it was thought by the ministry that there's a feasibility and an interest in an infrastructure for change. And you get to be a QPP if you cost a lot of money to the ministry, okay? And so basically more than 1,000 cases a year and more than 1% of the provincial health budget on your condition, you would raise to the level of potentially being a QPP. Does COPD qualify? Admission rates vary drastically across the province. Those two examples there. Unfortunately, a small minority get the best intervention for COPD, which is pulmonary rehab. We just don't have enough programs and opportunities. There is wide variation in the use of practices that are evidence-based, and I'm going to share a slide about non-invasive ventilation because it's a good example of how probably we need to do better. There is certainly evidence available with the CTS guidelines I've alluded to. There's international guidelines as well, and they're all relatively similar, thank God. There's infrastructure for change, not only best path strategy, but some of the other provincial programs that have come along. And unfortunately, it did identify that maybe 30-day readmissions is the thing we should be most focused on, and I don't think that's actually the case. And it's costly. This is Ontario data, 24,000, more than 24,000 hospitalizations annually. Total cost of $191 million, and the 21% readmission rates leads to additional expenditure of $38 million. So it is definitely more than 1% of the entire healthcare budget, and so it became a QBP. And on the expert panel, when we first met, we were told the following: don't think about the money. Doesn't matter if it's costly. We want you to this is the ministry talking. We want you to identify the ideal episode of care for a patient in hospital. Now, this was restricted to people in hospital because that's where the government can measure things. In outpatient care, very restricted what they can measure, and that's a constant limitation in this work. They include communities in the future, and actually we just released an update earlier this year, and I'll share some things on it. I'm afraid it's not earth-shattering because, again, the ministry can't measure a lot of the things we'd like them to. They also told us that this is a lot of work, but we need it done like in 3 months, and that's how we started off in the process. So, and we knew about these limitations, the absence of clinical data elements. So the ministry can identify a patient, but they have limited ability to look at their complexity level. They have that if you code for it. They may or may not know about all the comorbidities unless they've also had an admission for diabetes. And of course the psychosocial is completely blank to them. They don't have that data. So there's limitations to the data. We would want to see what drugs the patient got when they were admitted to a hospital for an exacerbation. The ministry has no access to that at all. Now, individual hospitals, if they have an EMR, would be able to track that and perhaps compare voluntarily among themselves. But there's limitations to what we can look at. There's only so many people to do a lot of work, and we were asked to focus just on the high-quality evidence. There is some, but it's limited. And I'll touch on a few of those as we go along. So actually our recommendations were pretty motherhood. Obviously, not necessarily at the time of admission, but at some point you should make sure your patient actually has COPD. Spirometry either before or after. That during an admission you should have a chest x-ray. Notice it doesn't mention any other imaging technique there. And especially where appropriate in sicker patients and arterial blood tests. And on management where appropriate, not for everyone obviously, oxygen therapy, non-invasive ventilation. And then we recommended that, of course, everybody gets a discharge plan, which of course is something the ministry wouldn't be able to measure on their own. And then we couldn't resist saying a whole bunch of things about outpatient care. This was back with the first guideline. And I think I've heard most of these mentioned today, this morning so far. And probably concentrate on some of the individualized discharge plans, the appropriate follow-up. This is actually a difficult one. Highlight this a lot, if I can find it. There it is. Second from the bottom. Follow-up appointment with 1 to 2 weeks. That's not always patient-centered care, actually, depending on the patient. And if they have an excellent family physician who keeps in touch and who has a good caregiver at home and who is recovering nicely from an exacerbation, not always required. And where exactly do we recommend that? I'll come back to that in a minute. So that's a little bit of an overview of what happened before, and I'll give you an update on the QBP recommendations in a little while. Every guideline, our group included, I've heard it multiple times today already, is you have to use a team approach. And I don't think anybody is going to argue about that. What there is a paucity of information about what is working in the communities. And we have positive studies, and I've heard some positive results today, which is great. A problem has often been replicating those in different scenarios, with different groups of patients, is not always as effective. And so I'm going to just show you some of the things we're doing. That doesn't mean they're going to work or they're the right thing to do. They're pretty similar to some of the things I've heard already, though. So, well, that's interesting. So my logo's disappeared. These are St. Joseph's Healthcare London slides because we have a lot of ambulatory chronic care programs, chronic disease programs. And there's our list of programs, and they include the cold program, asthma center, respirology clinics, etc., but lots of other chronic diseases, including diabetes, some heart failure, rheumatology, etc. And what we are hoping to do at St. Joe's is integrate the care for the patients who come to our building more than once to visit different specialty programs. And this is what our matrix looks like. So all of the clinics are listed alphabetically down the one side and across the top. And obviously this says that, I'm going that of the 258 patients who are in the pulmonary or respirology program, there are, if you go up that line, they also attend all of those other clinics. And you can pick any line you like. There's a lot of comorbidity. We know that in these individuals. And we have for a long time seen patients with rheumatologic conditions on the same day as they've seen their rheumatologist, but everyone else is kind of hit and miss. So we're trying to integrate the care. And we started with diabetes and our cardiac rehab program. Very similar issues, challenges, complicating diseases, etc. And they didn't talk to each other. And they have been for the last 6 months. And a portion of the patients are now attending both programs. And there's a decision made about you guys handle this part, we'll handle this part. And we'll talk to each other as the care goes forward. We hope over the next little while to add in the following groups in stages. So at least for the diseases we're managing in that building on Grosvenor Street, we'll be able to have more integrated care. In addition, I think we've got a very useful initiative going on called C3, and it includes both London hospitals, the family medical centers associated with those hospitals, because we do have a shared EMR, and CCAC in the Southwest. And it certainly has provided us with useful contacts as far as getting some of the other work done. And I've heard a lot of groups kind of talking about the same type of process. We've got a kind of a Health Links London-based program looking at the top 5%, which is a very common target nowadays. And later we're going to hear about another Inspired project. We're also one of the groups that does an Inspired project. And we have a COPD nurse educator, Pam, who is involved in assessing the patients, contacting them, and visiting them in their home where necessary, which has been an eye-opener, let's say. In addition, there are some programs based at LHSC that all the physicians in London are credentialed at both hospitals, so we work across the city. And I've been involved, obviously, in the QBP work that I've just described. And we are also initiated a new role at LHSC called a COPD navigator. And Caitlin's going to wave now. Hi, Caitlin. Who is an RT and is going to be our educator based in the respirology ward at Victoria Hospital, which tends to be where the sickest COPD patients. And to begin with, she'll help those patients and hopefully she'll become part of our team down the road. We have just received a good-sized grant from the Dean of our medical school to look at a chronic disease management initiative, including the 3 departments listed there. And it will include patients with either COPD or CHF who also have anxiety or depression. And so that's a big opportunity because obviously, although we talk about a lot of comorbidities that we manage together, when it comes to any mental health issues, it's kind of more difficult to involve. And so we're hoping, this is probably going to be based on smartphone technology in part, and it's going to be an interesting process going forward. And I just mentioned one challenge at the bottom of all of these projects that I'm personally involved in is managing the expectations. I mean, why are any patients with COPD now coming into the hospital? And also the overlap, where all of a sudden you find out somebody in that project over there is doing exactly the same thing you're doing over here. And that's something we have to be careful of, and that's just in the city of London. So. All right. So, as far as measuring our success, I'm going to flip back to a couple slides about the QBP COPD expert panel. Because what we were really asked to do, although we were told not to think about the money, what they really want us to do is, now that we're going to measure hospitals' quality of care for COPD patients, what should we be measuring? So that we can either incentivize, not very likely to get more money, or penalize hospitals that are doing a bad job. And this slide admits that basically our expert panel failed. We could not tell the ministry what they should measure because we didn't think any of the things they could measure were relevant. And they shouldn't dictate how hospitals are funded. And in fact, there was often the possibility of kind of perverse incentives or gaming that could go on. For instance, if you admitted a relatively moderate patient to your ICU, didn't really need to be there, you get paid for, okay, you get more money than if you just kept them on the ward. You can imagine how that could be impossible. And why would you send anybody home from emerge if you get more money if you leave them from the hospital? Well, because we don't have any beds, but there's problems with that. So we actually said it's inappropriate to recommend at this stage any indicators because of the lack of information. And we didn't think any of the measures in the second last line there were really relevant in this work, although they're frequently measured. And at least we have the opportunity from the data we can glean that Ontario could do a lot of good research in this, especially with ISIS and other clinical informatics systems that we have access to. So, how do we measure performance? The top 5 we've talked about. I'm going to come back to unplanned readmissions in a minute, and we're going to talk about mortality at the end. But 2 things we did mention from the group is, let's look at how the hospitals in Ontario use non-invasive ventilation, which is the treatment of choice for someone with a bad COPD exacerbation who's starting to go downhill. It's the treatment of choice, but we know it's not uniformly available, even in the busy hospitals in Ontario. And another thing is post-discharge follow-up, which is obviously work for another day, hopefully not too long in the future. And of course, we were well aware of this it was a 1-page article in the New England Journal back in 2010, and it looked at patients with congestive heart failure who had been admitted to hospital for management. And it showed an alarming association between readmission rate and death, but not in the way a lot of people might expect it. Because on the y-axis is risk-adjusted 30-day mortality rate. Mortality is going up when you go up there. And here's the 30-day readmission rate. And a readmission rate of 30% is dreadful. That's shameful, they tell us. You shouldn't have a readmission rate of 30%. So those people didn't die as often as the people who had lower readmission rates. Now, CHF is a complex disease like COPD. And I think most people know not always is kicking them out of the hospital within 4 days the best approach. And so readmission rates are actually inevitable, and in some instances necessary and appropriate. It's not necessarily the best measure, though, for chronic disease management. So we didn't want to recommend that. Controversial. So this, did the wrong one. So early on in the QBP work, the ministry told us, geez, there's lots of NIV in some hospitals, non-invasive ventilation in some hospitals, and 0 in other hospitals. So we said, hey, we need to look at that. Can you give us the data as follows? And so again, I don't really have a functional pointer, but listed down the left-hand side are the 20 largest hospitals in terms of COPD admissions in a year. I think this was 2010 or 2011, the data is from. And you can see they go from the busiest, 722, down to 382. That's still plenty of admissions. There's 160, 70, 160 or 70. Oh, I feel so empowered. It's all this home. All right, so Hospital 1 is very, very busy. This one's still pretty busy. There's lots of hospitals that aren't as busy. And I'll actually, now that I have a pointer, I'm going to show this one. Number of total COPD cases that had ventilation, and ventilation includes both non-invasive and tube, okay? And look at the variability in that column, okay? So there is a hospital down here that admits 400 patients and ventilates almost a quarter. And yet the one up, let's say here, admits a lot more patients and ventilates one way or the other, a very small minority. That can't just be by chance. And the patients aren't that much different in our 20 busiest hospitals in Ontario. Then they look, okay, there's the cases with ventilation as a percentage. There's the ones that are invasively mechanically ventilated. There's the ones whose non-invasive positive pressure ventilation. And the last column is the percent of the patients who were ventilated that were done non-invasively. You would hope that COPD patients going down the tubes, most of them should be given a trial of non-invasive, okay? And then some of them will end up with invasive ventilation. Look at the difference in the percentages in this column. The 5th busiest hospital does no NIV. That's not standard of care anymore. I'm sorry, it's not. And I understand if you've got 20 admissions a year, that might be a little more challenging. But for the 5th busiest hospital not to have it, or the 7th, or the 10th. And then this hospital, which I particularly think is probably an excellent hospital, does 43%, which gives me a bit of a, maybe that's about right. And the busier hospital than us does 7%. And look at the variability in there, it's 82%. So if you do 82%, you're probably giving everybody a trial of NIV. And we know that not everybody needs a trial of NIV. They need to go straight to, and of course you can bill for NIV. You know, it's a complexity, which you get extra money for. Hopefully that's not why they're doing it. But I mean, this just points out the incredible variability that exists. All right. My pointer down now. So managing. How are we doing? Okay. You've got some slides about from the CTS guidelines, and so these first few are going to go through fairly quickly because they're part of the master slide deck, and I'm sure you've seen them all before. Although today we're kind of focusing, or we have been focusing on the bottom right hand to avoid healthcare resource utilization. There's all kinds of other good reasons to prevent exacerbations in patients with COPD that are much more relevant and important to the patient than how much he spends in their hospitals. The optimal strategy has always been to prevent them altogether rather than treat them when they arise. And these are the things that were listed in 2008 that have been proven to prevent exacerbations. And I don't think there's anything there that's revolutionary, but note number 3, self-management education with case manager and written action plan. And even in 2008, the CTS said that an action plan by itself is not enough. You have to wrap some type of education and case manager around it to be effective in COPD. So all of those things are recommended, but one of the key messages from those guidelines is on this slide. And of course that was driven by an all-Canadian study done in Montreal by my colleague Jean Barbeau, who was the first to really look at this in a systematic fashion. And you've probably mostly seen these slides, and it looked like the self-management group in light blue had a 40% decrease in admissions for exacerbations, 57% for admissions for other reasons, and reduced ER visits. And so this was heralded as a major breakthrough in the importance of this, and the bugger just went on an international speaking tour everywhere. And John's a great guy, and he's a trusted colleague, and even he is now sobered by the fact that when people tried to replicate his results, they mainly failed. And it probably related to the special team they had in Montreal that may or may not be translatable to other locations. Now, I think we're talking a lot about this today. And Jean also had a huge amount of passion and built his career in this area. So there was somebody who had obviously had a vested interest. That doesn't exist in every hospital in Ontario, even the busy ones. And that's a challenge. Even better, in addition to the patient educational programs that are listed at the bottom of this, they should be in a full pulmonary rehabilitation program, which includes the exercise training and other counseling. And as I alluded to in a previous slide, that's available to the small minority of patients, even in the rich province of Ontario. Benefits of pulmonary rehabilitation are several, including now reduced exacerbations. There is a little issue with the durability of the effect, in that people coming out of an 8-week program always improve. By 6 months and 12 months, a little harder to show, but certainly it's a very, probably the most powerful impact of any intervention in COPD, including our puffers, but we don't have access to it. So we're looking at doing, obviously, hospital inpatient is not feasible. Can we do it at the hospital, but as an outpatient? There's several programs like that in Ontario. Can we do it in medical centers, fitness clubs, etc., which I know there's lots of examples in our part of the province. And maybe for some people, could we do it at home? And a lot of us have been started talking about rehab light, like what parts of the program can we do that patients will still benefit from without, because pulmonary rehab in the traditional sense is expensive. I'll come back to that in a second as well. Luckily, exercise is important. Maybe not just as good as pulmonary rehab, but at least we can activate our patients and tell them to exercise, and we heard several examples today of how we might do that, so that's good. And as far as medications, in 2008, it was really simple. Okay, so if you had frequent exacerbations or you had very severe disease, they said you need to be on triple therapy. There was only one long-acting anticholinergic at the time, which was tiotropium or Spiriva, so they could put it on the slide. It's the only one you could use. And there was 2 combo products, inhaled steroids with a LABA, and so they put them on the slide. And Ventil and PRN. Don't pay attention to the Theophylline thing. So that was really easy back then. No, not so much. All right, so those puffers are still on here, obviously, and still available. And even down in one corner there, there's a Spiriva Respimat that is now available. But there's all kinds of other anticholinergics, long-acting beta agonists, and combination products out there now. And it's confusing. It's confusing for a respirologist who deals with it every day. It must be confusing for family physicians and other primary care practitioners, and especially patients. They all work, or they wouldn't be on the market. That is, they do what they're supposed to do, bronchodilate, reduce inflammation, etc. But exactly where they fit is a challenge. Luckily, the group at the CTS had the good sense to begin with to talk about categories of drugs. So we presume if you want to be on a long-acting anticholinergic, if you wanted to be on triple therapy, you could be on any of the long-acting anticholinergics. We haven't proven that. But it's likely because they have very similar effects. And there's 3 of them now on the market, and there's a 4th coming soon. And you could be on now the 4 or 5 ICS LABAs that will be available. But now we have products that combine a LAC with a LABA. So now what do? You add just an ICS. It's complicated. So we think we can still follow the guidelines. We don't have overwhelming evidence that that's going to work. It's wonderful, though, to have a choice of therapies for patients, and especially a choice of devices, because some people do definitely prefer one over the other. The evidence just isn't robust. So here I said that the QEP group got together again. I wasn't part of this later phase because I guess I wasn't considered post-acute. I certainly feel well past acute by now. But, they brought a different set of experts together. I think it was more family practice oriented than this particular group. And they looked at other recommendations, and they made a few things that were interesting, I thought. We should look at a case-finding strategy for alpha-1. Now, if we're waiting until patients are admitted to hospital for an exacerbation to find someone with alpha-1 antitrypsin deficiency, we probably waited way too long. The second one is interesting. So we always wondered about this. Why do we stop the patient's Spiriva or other anticholinergic when they come to hospital and ply them with Atrovent? Actually, there's no evidence that that's the right thing to do in COPD. The group kind of said, no, just leave them on that, the anticholinergic. And I'm not sure about that, but that's what they recommended. Obviously, early ambulation, daily physical activity. And look, they said that we shouldn't be sending all of our ventilation patients, non-invasive and otherwise, to the ICU. We all should have a dedicated unit in our hospitals, like Victoria Hospital does, but UH doesn't, where we can look after these patients with a team on the floor. Now, that's so easy to say, that that's what we should do. But it's complicated to organize, and it can be expensive to start. And so some of these recommendations, I think, are the right thing to do, but they may not be achievable. Because of the evidence that some patients with frequent exacerbations might benefit from chronic azithromycin largely, they mentioned that you should consider that in some patients. So that's for the acute episode. That's still kind of a hospitalized patient about to go home. As far as the transitional care, we've talked a little bit about this, but do you think currently that all 160 hospitals in the province have a patient-centered education and health literacy program? And that we have the ability to identify and review patients within 1 to 2 weeks of discharge. HealthLink's got a big plug in these guidelines by saying that's the standardized approach to transitional and coordinated care planning that should be used, so that's good, and that's why we're here today. And then they made a bunch of ambulatory or community care suggestions that are all based in some evidence and are feel-good statements and would be good, but they're just not that easy to achieve. Functional's important. Follow-up appointment within maximum 1 week of discharge. I would agree with follow-up contact within 1 week of discharge. I don't think all of them need to come to hospital to see. Hospital's the last place you want these people to come. It's the last place they want to go, that's for sure. So maybe there has to be different ways, and if you've got an engaged family practice who has a COPD educator, that's much better probably if we can talk to each other and make sure we coordinate care. Community-based multidisciplinary care. Now I bet there's a few people in the audience who would consider themselves care coordinators. And I wonder how many of them deliver on this right now. That's we all aspire to, right? But often the resources aren't available, and especially in our communities that are further afield. And it's the right thing to do, but it's easier said than done, and it can be expensive. And I'm not sure how the ministry is going to do that. Oh, and we also should be good at managing all the comorbidities these people have, of course. The expert advisory panel kept hammering away at pulmonary rehab because OTAC, which is a branch of the ministry, basically told the ministry in 2012, pulmonary rehab in this province is a disgrace, you have to fix it, you have to fund it. And the advisory panel agreed with that, and they should fund the pulmonary rehabilitation implementation plan that was submitted in 2014. Of course, it was millions and millions of dollars in cost. So, who wants to join me in holding our breath until the ministry funds pulmonary rehab in the province? It's the right thing to do, but it's a challenge. I was going to skip these slides because they might be too provocative, but I've got some time. I've seen a drift in the use of oxygen in COPD patients beyond what's been proven to be beneficial, and a little bit of a drift in how often we assess patients' oxygenation and why. So I'll just remind people of the evidence. This is from the 2008 guideline. I'll just let you read that. I'm sure most of the people here know about that. And here's the results of the 2 sentinel trials that were done in proving that oxygen was beneficial. Obviously, the survival is going down, so staying up at the top is the better thing in the NOT study there. One thing I'll remind you about these studies. You see the dates in the bottom left-hand corner? What buffers did we have for COPD in 1980? None. Well, we had Ventolin, which I guess is but no COPD. Atrovent came out in 81, 82. And we had none of the medications we have now that really have transformed COPD care. They have been very effective medications. So back then, oxygen could be proven to save lives. If we did the study now, especially with this wraparound care we have for our patients, it's a good question whether it would help or not. So let's not overuse oxygen, and I have seen some drift to this. One example is people who don't qualify for oxygen somehow can either trick the authorities to getting oxygen because they desaturate with exercise. That's a very common scenario. Absolutely no proof that it's of any benefit at all to COPD patients. There was a big Canadian study that was attempted looking at patients who desaturated at night but didn't qualify during the day, randomized to oxygen or sham. No difference in outcomes for those that were randomized to oxygen. And we also know, and are asked frequently, Pam knows because we see patients together, if one of my COPD patients comes in and says, oh, they bought an oximeter, I kind of turn gray. Because that wouldn't have been my suggestion. I mean, there's very specific instances where you might do that, but that is not recommended in any guideline in the world. Okay, better move on now, so I don't inflame any. I should have asked if there's any oxygen supply companies in the audience. I would have said it anyway. So I'm going to close with a few slides looking at real-world outcomes of some of these measures. And this is the study that I think made us pause as much as any. And I know Jean Bourbeau, after we talked about this study, decided we really have to rethink some of these things. Because this was published in 2012, and it was a VA medical center study in the United States. For those of you who have visited one of those, that is actually the part of the American healthcare system that is most like ours. The care is generally free, and they have, spoke hospitals, or hub hospitals, with spoke clinics, et cetera, et cetera. And so they ran a study to show that comprehensive care for COPD was beneficial. The proposition is at the top there. Results of early trials, like Borbeau, were very positive, but later studies a little less compelling. And of course, in all of these studies, the patients look different, their severity may have been different, the interventions may have been different, and maybe that explains why some were positive and some weren't. So let's standardize it across 20 VA centers in the United States and give them a program that included COPD education, individualized treatment action plan, and telephone case management. Not bad, good start as far as wraparound care for COPD. And these people can come back to the VA Medical Center anytime or to one of the satellite clinics for appointments. And then versus usual care, which presumably meant not very much. So, I mean, come on, people. All the fans in the room, I mean, this is going to be a winner, right? Enrollment began in January 2007. They enrolled 426 patients, and thank God they put in something called a Data Safety Monitoring Committee. Very routine in drug studies. New drugs come out, they always have a Data Safety Committee to make sure changes aren't happening that could be dangerous for the patient, either in a positive or negative way. And they could stop the trial if the two lines, for instance, of outcomes were diverging. They said, hold it, time out. Don't enroll any more patients. There's a difference in the death rates in the two groups, mortality. And for the next few months, they instructed all the hospitals to do a very intensive look at all the charts of all those patients, independent reviewers actually, to see if there's anything else that could explain this divergence, like they were actually sicker people. Or some people said they got intervention, but they never received a phone call. Looked at all of the things they could. They did that intensively for 2 months. And they couldn't find an explanation otherwise for the difference in mortality. So they stopped enrollment in 2009. The study was never completed, and the patients in the study were observed for 6 further months. The difference in mortality is listed here. Probability of failure, I think most of us would agree that death is a failure, and days out in the study. And the top line is the comprehensive care patients. And the bottom line is usual care. The patients in the intervention group died twice as often as the patients in the usual care. After the study, you notice it wasn't published until 2012. After the study, they just scoured through everything they could look at to explain this difference and why this must be fake, maybe must be fabricated. And they couldn't. They couldn't find any difference. They got the same minutes of telephone time with the coordinator in the two groups and things like that. And no substantive differences. The hospitalizations were actually no different in the group. And people presenting with acute exacerbations were no different in the group. So if twice as many people in the one group died, why wasn't there more acute exacerbations and hospitalizations? They hypothesize, that's all they can do about it. So, chance, like dice, that's what happened. Maybe we measured 150 things to try and explain the difference, but we didn't measure the one that counted. That's a little unlikely. Is self-management and education bad for you? Probably not. Some combination of the above. And my comment about no hospitalization or no difference in hospitalizations and acute exacerbations, the best theory going around is, believe it or not, some of you maybe should be doing this right now, is that patients with COPD who get self-management are overconfident and don't call their healthcare providers when they get sick. I can manage this. I can't think of many other explanations. So, in summary, improving patient outcomes and experience, obviously a noble goal, and that's why we're all here. Inpatient interventions in our work was constrained, but now with EMRs, people from London will know that's or from our region, or know that's our Hugo is our EMR. but probably the improved transitions and the outpatient care is way more important than what we do in the hospital. Although we could fix that NIV thing a little better than it is. And obviously, if you drive funding of hospitals by quality of care and measure the wrong thing, you're probably not doing a good thing. So thank you for your attention.
Thank you very much, Dr. McFadden. That was perfect. You brought the 4.5 hours of material down. Something that I think not only is a little bit challenging, but also will give us some direction today. Because the goal of today really is to take all this stuff here and push it out here, so that you guys at the front line can actually make changes in the way you work together to improve care for people with COPD here. So I've been tasked. I think I'm not sure why I was asked, but I've been tasked, I guess, as the chair of the primary care network to look at some of the data for care and birth. So I'm happy to do that. Recognizing that there's data that is collected for the health link and data that you'll collect as a team to drive changes in functions. It might be helpful for me just to know, in the audience here, how many people do we have who are physicians or nurse practitioners? And how many people do we have that work with the family health team? Great. And how many people do we have from Exeter?
Primary care service is ambulatory.
Nice. Okay, so here's one of the challenges for the health link here, and this is partly my AFCO hat. So we have a number of patients enrolled through family health teams in the province, and here in Perth we're actually really good with that. Exeter doesn't have them. And so the challenge is, as a health link, can we support Exeter with other family health team resources to help them sort of do COPD treatment as well. So I'll throw that out there. And I won't go on too much about AFCO stuff, but one other one is that an ad here for D2D. So there's data to decisions. You can get 11 for the family health teams here, not for Exeter. You can get 11 measurable things just by applying to ISIS that are apropos to this whole stuff. So I can tell you right now that our 7-day follow-up for the big diagnoses from the hospital in North Perth, family health team, is 84%. So 84% of people who are discharged from the hospital are seen by somebody within 7 days. I can say that because we belong to D2D. We encourage everybody to do that. Cost is one of those things measured in D2D as well. So in BC, highest risk patients who had a strong primary care team behind them cost the system, total system cost of $12,000 a year compared to $30,000 a year if they don't have that. So we're proving our value here, and I think the health link takes it to the next level, and I want to congratulate the planning group. There's been lots of planning, as you can tell, for the health link. We're taking a QI approach to this. Not all, most actually, health links in Ontario aren't doing that. And to take we're trying to bring everybody together, trying to make it better, and look at the data as we go so that we know that we're doing a good job. It's a really good way to go. It's been maybe a bit slower. I know you heard today that case conferences are difficult to arrange. That's true. So, okay, let's look at the data. And then I'm going to give you 3 tips. My advice sort of going forward in terms of how you and the team can make this work. I'm a little worried you'll feel overwhelmed at this point, because there's been lots of really great stuff up here. Okay, where are we? Okay, aim statement and data. So you guys are trying to make things better at your level. Massive amount of work that needs to be done in the material. It's great. So this, you could get this. So if you look at the box here for this particular patient, you see a graph of how many times they've been in the hospital, to the emergency room, and if they're involved with CCAC. And you can get this. In fact, they're being sent out to you now to your IT custodian, who I'm guessing that is an archive. I'm not actually sure, but you can get this information now. So as they identify, pardon me? Oh, let me tell me. But anyway, as they identify these high users, they will give you this, and then you can plug in where the care plan is done, and then compare it to later. And you saw the graph that the IDEAS team did, where there's a definite decrease in emergency room use and patient discharges from hospital. So this is something you can get, or if you have a patient who you'd like to know what this is, apparently what you have to do is get the number, which CCAC has if they're on CCAC services, or the hospital has. So if you have a patient and you're curious to know what their utilization is, you can get that. Plus, these will be sent out to your team. I'm not sure if they are now. I haven't seen them for my patients personally. But it's actually a great picture. And it's two, per patient, like an individual patient, so it's cool. And then sort of looking at it from a helping perspective, so bringing it out to the whole population. We know based on emergency room use, urgent care use, and hospital use, that the number of the top 5%, who by the way may be different every year, I think that's a challenge for us. They may be changing, but the top 5%, there's 2,253 people in Berlin, and there's about 354 people here in Perth. So per family health team, there's probably around 30, and you can kind of do the math about trying to identify those. So how many care conferences should you be doing? Is it just COPD in your particular family health team to kind of get on top of this? It's almost overwhelming. And then this data comes out, and I think for today we want to kind of know how should the health link follow this data. So you have the month, and then the number of patients who are fit the population, as well as ED visits, inpatient discharges, total lengths of stay. So what I would like to see is a run chart on maybe a quarterly basis with these numbers in aggregate form. So something like total number of high-risk COPD inpatient days per month or per quarter, and we follow that as a health link, and we expect that to get better. And that's why these aim statements are made, so we kind of draw everybody together. This is our goal, and we don't have one in particular for the COPD high-risk population, high users. I would suggest something like we want to reduce emergency room utilization and inpatient discharges by 10, 20% by next year. That's a challenge. And then the thing with the aim statement gets people thinking, how are we going to do that? Now the data that you see presently, I think it's being pulled out yearly, and so personally I'd like to see it a little more frequently than that. I think quarterly or every 6 months. I don't know how maybe plans these things, but we're going to need to see the data in our face a fair chunk to see if we're making a difference. So see, we're going to get a lunch. Here are my 3 tips for you guys, because you have a massive amount of information here, and you want to go out. So for your teams, I would say keep it simple. So you're gonna talk today about things you can change to make COPD care better. Pick something that you can change by next week. We are going to see how many smokers we have in our practice. We are going to identify what's the pneumococcal vaccination rate in our patients with COPD. We're going to look at how many of our COPD patients actually have spirometry ever done, which you shouldn't 100% because you can't diagnose it without it, but seriously, lots of people have COPD diagnosis and don't have that on the chart. So there's all sorts of things you could pick that you could start looking at in your practice next week. Number 2, care plans. So you've heard today, I think the take-home message is, well, care plans, one is they work, we should do them. How do they work? 2 is the patient's involved. 3 is there's no electronic solution for sharing these yet. That's a barrier. It's supposed to come. I'm worried that when it comes, it still will be a barrier. So you may have to work around that, but sharing the care plan is an issue. But the care plans work, logistically very challenging. Everybody, every team here, I would encourage you got to do at least one. How many people have been involved in a care plan? Yeah, smattering. So I've done about 5, and very difficult to organize, very good things. We really believe in them. The data supports them. You got to do at least one. So simple measurements in your office, do a care plan, and then the 3rd one, use D2D because it's a really good, your family health team are really good set of indicators to help you drive all the improvements, including this stuff. For instance, we have our readmission rates. So that's really all I want to say about the data.